Hello, everyone. Welcome to a special edition of Frontrunners Innovate. We are in a series of podcast episodes centered around healthcare innovation, and I am blessed to have a partnering organization with me that is seated here. You'll see a couple of gentlemen here with LeagueMed.com, and they'll explain what that is and how this relates to the people that you're going to be meeting over the next few weeks. There is a center point, a focusing point on funding, and then everything that wraps around that to get innovators that are disrupting in the spaces around healthcare and medicine and medical devices into our society and into the places around the globe where they can do the most good. But what I want to do at the very beginning is introduce you to the founders of LeagueMed.com, and they'll share a little bit about what they're doing. So I'm going to start with John Gallagher. So John is the CEO of LeagueMed. So John, you have the floor.
Thank you, Mary. Appreciate it. So we founded LeagueMed about 2.5 years ago, and the sort of inspirations were twofold. One was here in the U.S. for many years, the private markets were very constrained in who could participate, but it is the field of innovation and entrepreneurial endeavor. And with the passage of the Jobs Act in 2012, there was a fundamental restructuring of the private markets in the United States because Congress and the legislators at large realized that capital formation, job creation resides with small business. More than half of employment is with small business in the United States. And how it relates to what we're doing is we saw an opportunity. It relates in some measure to Paul's experience, and he'll speak in a moment, in dealing with healthcare professionals and healthcare institutions for many years and rendering a variety of financial and advisory services to them. The other side of the inspiration was that I had developed a relationship with a family office in New York called the Viscogliosi brothers. They are among the most significant private investors in medical devices in the world. They've just recently bought the global spine business of Stryker, and they were seeking to develop a boutique investment bank to finance some of the other opportunities that come their way. In that relationship, we explored an idea enabled by the liberalization of the private markets in the United States, which was to have an online platform that would feature rising medical technology companies, not startups, but companies that are poised for commercial development or already in revenue and are seeking capital to grow and accelerate their commercial proposition. And the need for incremental capital in the innovation ecosystem in healthcare is substantial. The venture guys have really retreated. There's lots of money for startups and incubation, but that sort of first step towards commercialization is an area where there's a great need. And we saw an opportunity in this new regulatory dispensation to build this platform, feature these kinds of companies, and raise money from healthcare professionals and aggregate many hundreds, even thousands of smaller contributions to satisfy the capital requirements of these rising medical technology companies, as opposed to going out to institutional investors and finding 2 or 3 or 4 people who are going to give you many millions of dollars. So that's what we set out to do a couple of years ago. We launched the platform a couple of months ago, and the reception's really been extraordinary. And we're part of, I think, a larger phenomenon in finance and business generally, of doing business online through this medium we're using today to communicate, making it self-directed, and inviting the mass affluent to participate in what was, until recently, something which was very much the domain of the great private university endowments, the great philanthropic establishments, the Ford Foundation and the like, the more sophisticated public pensions, and other sophisticated institutional investors. Now the opportunities that you find in the private markets can be more widely distributed to the mass affluent, and as it concerns our business, there's a perfect correlation between the product, which is, innovative solutions for healthcare, and the audience, who are people who are highly educated, professionally engaged, relatively affluent, and who can appreciate, by virtue of their immersion in the business and their education, the efficacy of the solutions being brought forward by these entrepreneurs. So that's what we set out to do. And I would just say that as a personal note, I spent many years in the asset management business, alternative investments, selling, technique, style, statistics, and all this sort of stuff. But it was very far removed from the actual application and utility of the application of capital and its social utility. And here, if we can raise money for these companies and these entrepreneurs and these innovators, those companies are going to make a difference in the lives of other people. And, that's a great thing to bring home tonight, that we can do good by doing well. And so that's a big part of our motivation with this business. And, Paul has been instrumental in helping bring this vision to life.
Great. Thanks. I appreciate it, John. Well, let's move over to yet another Paul. I just realized when you said Paul that we have two of you on the call, Paul Cella, and who is partnered with John Gallagher and LeagueMed. And Paul, why don't you share just a little bit about your background in key arcs and how you came into the picture with LeagueMed?
Okay, well, good to see you, Mary, and thanks.
Sure.
So I'm the managing principal of the Key Arcs Group, and I've been working with physicians, healthcare for about 30 years. And John and I partnered in the creation of LeagueMed, like he said, about 2.5 years ago. But my background has been solely focused on working with doctors, practices, clinics, hospitals, and my practice has been built around how to save them money and we have a unique process on saving them money on their second largest spend item, and that's their benefits. So we have a process where we typically save the doctors, the hospitals, the practices 20 to 40% bottom line, and they can take those monies, put it to their bottom line, or redeploy those to get richer benefits. And oftentimes we redeploy a portion of some of or all of those savings to get richer benefits for the C-suite, the executives, the doctors of an organization. So we insure thousands of physicians and practices around the country and have large hospitals and, like I said, large situations. But that was the marriage with John and I in the beginning. So we're in the healthcare space, and John's wonderful idea to bring investment to the investment need and innovation need. It was a marriage. That's how we kind of collided.
I think we should also note that Paul and I grew up together, so he's known
besties. I like it. We support everything that you guys are doing. We just think it's a wonderful idea and a platform to bring to the frontrunner community. So speaking of frontrunners, I would like to introduce Dr. Angela Yaneffi, and who is in the UK. You gentlemen are in New Jersey. We got the other Paul, who is our guest, Paul Christie, in the UK, as well as Angela. And Angela has been a frontrunner in my community for a number of years. She is in the healthcare space, and there's a little bit of strategy on my part to bring her forward just because I know what she's doing right now, and I feel like it's relative. She's done a lot of things over her life, so I'm going to let her share a bit about her background. So, Angela?
Oh, thank you, Mary. Good afternoon, everyone. It's absolutely great to be here and sharing what we do. So my name is Dr. Angela Yaneffi Kennedy. I live in the UK. I've traveled around the world, worked around the world as well. I do have experience in IT, telecoms, but then my passion has always been healthcare. So I went back to uni and did a degree, and I did set up quite a few NGOs in Ireland and in the UK and in Africa as well. My passion is health. How can we improve, enhance health for the less privileged, mainly, and people that can't afford it? So I love innovation, new technology, and I just believe the future is technology. At the moment, I felt there was a need, there was a gap of international companies going into Africa, and and going through all the red tapes. And I thought I could kind of provide a consultancy where I can actually help the international company through the regulatory requirements and support them in the market as well. So yes, I set up a company here in the UK. So, and there comes in BioPanda. In 2022, I did a project an NGO project in Gambia. And I bought the products, the rapid testing kits. So I just started a conversation with BioPanda. And at that time, they were not in Africa. They were selling one or two for universities and college research. So I thought, yeah, we can actually try going into Africa. But I'm originally from Nigeria. So you all know Nigeria is one of the biggest market and one of the hardest market to get into. And literally a lot of companies have tried and turned away because there's too many red tapes. So I have been working with them in relation to ensuring that the products are registered correctly. The product is BioPanda. They're based in Belfast. The feedback and the response from clinicians have been absolutely positive. Hence the reason why we're in Nigeria right now. So my focus is really talking to the stakeholders, the people that can make decision on buying things, the Ministry of Health.
She is such a go-getter. You will never find somebody better than her. Like a bulldog. Put her in a point in the direction, let her go. Angela, I'm going to break away just so I can get Paul to share a little bit, Paul Christie, to share a little bit about his background, what brought him into his innovation, because now you'll see probably why I brought Angela to the table. But go ahead, Paul, and share a little bit about your background,
Sure.
and then bring us right up into TachMed.
With pleasure. So, hi everyone, Paul Christie. I'm the co-founder and CEO of TachMed. And my background probably looks a bit incongruent with many people setting up medtech businesses. It's neither medical nor technology as such. I was an investment banker turned hedge fund manager turned private equity investor. And in my last role in private equity was one of the co-founders of an investment fund that focused on Africa, and in particular agriculture in Africa. And we, coming straight out of the 2008 credit crisis, a lot of my colleagues were very much from the global macroeconomic and geopolitical space. We identified 7 big themes for investment, of which agriculture was one, education infrastructure were others, health was one of the big ones. Raised a lot of money from US endowments to invest in developing agricultural enterprise in sub-Saharan Africa. And as part of that journey, the movement, if you like, for impact investment, doing good alongside private enterprise was taking shape. And you probably saw the Rockefeller Foundation created the Global Impact Investment Network and things like that, guiding principles for investment managers. Colleagues of mine and peers of mine helped found the principles for responsible investment at the World Bank to guide those kinds of impact investments. And so we found ourselves invested across 5 or 6 countries in sub-Saharan Africa, managing a lot of land, developing a lot of agricultural operations. And I think at one point we employed about 27,000 people. I know in Africa that can happen very quickly. And these people needed transport to get to their jobs. They lived in villages which needed education. They needed energy, renewable energy. They wanted health. And a lot of health in Africa, 45% of primary health services are provided by faith-based organizations. So very community focused. And I realized very quickly that, alongside agriculture, we wanted our workers to be fit and able, access to diagnostics, access to medicines, even access to healthcare professionals was very limited. And we may be used to having an insured payment system or a state-funded payment system like the NHS in the UK, but that doesn't really exist in sub-Saharan Africa. So a lot of health services are paid for out of pocket. And a lot of healthcare professionals were being encouraged to come over from Cuba and from India to provide those services. There are only so many people. So whilst working in agriculture, I could see the strains on the system of limited resources of people, facilities, testing, the lack of technology. But at the same time, you could see really exciting innovation happening in the establishment of 5G networks across sub-Saharan Africa. And you probably saw, Angela, across West Africa as well, with Helios towers and such like. And the fact that the rate of technological adoption in Africa was higher than in the Western world. In Kenya, 99.9% of the population using mobile phones to bank with, getting their news and their daily feeds on mobile phones, 80-year-olds doing their banking on mobile phones, a level that you wouldn't see in the US, in the UK, or even parts of Asia. So Africa was innovative. And it was that reverse innovation which even people at Harvard Business School started to really notice in frontier markets in Africa that was giving us ideas to bring back to the West. And that, for me, really hit its pinnacle with the development of M-Pesa, which was mobile money in Kenya, that was enabled by the architecture provided by Vodacom, the telecoms company. So that really predated Apple Pay. So a lot of things have happened in Africa that I think have driven a lot of change and innovation in Western markets. And we're really good at transforming those into big businesses and scalable businesses. So hence I came back from Africa and I wanted to focus on health, came out of agriculture, set up TachMed with some seed money from Lord Beaverbrook's foundation, the Beaverbrook family office. And we started to focus on how could we get health data into a system where we could process it in such a way it could drive a new suite of products in reimbursement, in insurance, and healthcare provision. We really saw a lack of digital data in the health space. And so from my background working in financial markets, I thought, well, why can't health data be systematically collected and traded in much the same way as financial data? And it would enable algorithms to automate a lot of the processes, reduce their cost, improve productivity in certain workflows, and maybe build capacity in a system that is antiquated, that is really dependent on human resources. And I started talking about that in 2018. I remember very clearly giving a macro presentation saying, there's going to be a catalyst, things are going to change, health data and the generation of health data is going to be the great equalizer, the great leveler. Whether you've got a birth certificate, an electronic or a paper health record or not, testing your health status in real time, systematically uploading that data and giving access to it, to your health professionals, and to those people that are pricing reimbursement and health insurance products, going to make it cheap and more efficient. And we started looking for technology that could enable that. And that kind of manifests itself in this, which is our first product, which is the Nespresso machine for health. Our cartridge system that says, you know, here we have a potentiostat reader. It connects by Bluetooth to your mobile app. Here are the cartridges that are using biosensors. And really, depending on your budget, the sky's the limit in terms of where our research and development can take those diagnostics. And they will generate that real-time data that, you know, our friends in the reimbursement community can use to dynamically price the provision of health insurance and services. And if we get enough data, and there's a big question around health data, which was really thrown up by the pandemic, but enough precise, reliable, and attributable data will change the way we allocate resources. And I'll just come back to that and say that during the pandemic, foundations like Rockefeller realized that there just wasn't very much digital health data around. There are a lot of analog data sets that were not fungible. When you tried to put them together, they created skewed data, Frankenstein sets of data that gave very unreliable trend curves. And policymakers were trying to make decisions based on that. But now if you could get really reliable data and it's more predictive, now, a few years on, we're not talking about just influencing policy, but we're talking about correctly driving or training large language models in AI that could drive the next generation of virtual primary health services. And then, coming back to my point earlier about Africa and everywhere else for that matter, bringing doctors in from Cuba, Africa. In the UK, we try to hire doctors from Australia and India and such like. It'll become less acute because with enough data, you'll get more of a virtual doctor that's present but not there, more automation, and get people diagnosed sooner. Maybe you'll get more preventative healthcare. That's our goal.
Paul, could you just describe a little bit more of the device that you were handling a minute ago?
Sure. So this is a potentiostat you would find in any laboratory, PCR lab. And usually it's a big piece of kit, costs several $1,000s. We re-engineered it into a consumer medical device. It costs about $150. We expect to get it below $100 in due course. And then this is an adapter depending on what cartridges we have for urine, blood, or such like. These are rather like an espresso machine. You can choose which tests you want to do, or your care provider could decide what they want you to test for, and they can send them to your house within the hour. So the wonderful example I would give is a real life example of someone I know in one of the US regulatory agencies whose child had strep A, and they wanted to go and see their doctor to get a prescription. They could have tested at home with a cartridge for strep A, tested, done the test. If it was positive, the signal would go up to the mobile app, and it would go straight through to their telehealth provider that has access to that data, and they could write a virtual prescription and send it through immediately.
I mean, in a way, it's analogous to what we're doing. You're sort of self-directed. You're putting it in the hands of the patient. If it's not, you haven't had a traumatic, injury, and there's an enormous amount of time wasted just going into the clinic, waiting, reading boring old magazines from 6 months before until they have time to see you, and then hours thereafter waiting. It's an efficiency for everybody.
We're the only industry that I can see that still expects people to go in, sit in a waiting room, and take several hours out of their day, potentially catch an additional ailment in the waiting room while they're waiting to be treated for their original one.
It's the only way you're going to serve this growing population. The infrastructure here in the US isn't equal to the demand, right? So more and more is being pushed out and away from, the hospital or the clinic and into the home with telehealth and what have you. And what you're pioneering there. That's exciting.
You're very
I like what it could do for the aging population that has a struggle even getting transported to and from doctor's appointments for things. And because of that, and because of a few other factors that make it so challenging, they just don't go. They just, they don't get it done. And so being able to have something like that available to home health or to, even to the family itself to be able to help. I mean, UTIs and things like that are so common. Talk about the broader scope of what happens from a global perspective when there's enough data in place and how predictive that can be.
So the whole point of our system is to make it cost effective enough that it could be deployed at scale. Not just to those people that have Blue Cross or other occupational health schemes, but to everybody. And by deploying it at scale and getting everybody to use it regularly, you get a very diverse and very current data set that's dynamically updating second by second. And we've developed dashboards where from a health provider right up to a health security agency, you can literally see the emergence of disease, the spread of disease. It's rather like one of those apps you probably played during the pandemic, Contagion or something like that. But it's not just about infectious disease. It's about looking for patterns between indicators of chronic disease that can predict whether you're heading for a heart attack or whether inflammation is taking you on a pathway to some kind of condition. It might even be that in the future, those indicators are linked to some cancers or things like that. And I think if you have a diverse enough population that you're sampling, that you can find those relationships more clearly and you can minimize bias in the data. One of the biggest concerns for me when I started this was that in the UK, we have something called the Biobank. And one of the biggest complaints about the UK Biobank is that it was largely made up of contributions from white middle-class males. And the paucity of data available from women was affecting research and the development of new products. We really want to bring everybody into our data pool so we can really drive research and development into tests that are relevant to every part of the population. And that translates into the world of generative AI. Because when you want to generate those insights, you can train those models to reflect any bias or to take into account any bias in the system or to reflect the overall makeup of the population.
Paul, how do you distribute this? I'm sure there's more than one way, but what is your vision there?
Our vision, we've got a strategic partnership with AWS, and they have some wonderful distribution channels, whether it's through their sister company at Amazon or through the AWS marketplace. But our focus is on providers and payers. We don't intend to go direct to the consumer. We want to work in partnership with professionals, clinics, with the system to get to their patients. And that could involve community health organizations as well.
Well, just got a question for you. Obviously, I do have colleagues who are actually using the telehealth within the community, looking after patients who are over 65 or patients who do not want to be in the hospital setting. So they're getting the support remotely. I know the NHS has started rolling that out. I think in the last year or two, it's a bit more common now. Is there a possibility of working with them?
Absolutely. We are already working with 2 private primary care groups in the UK. We started off by collaborating with the NHS Academic Health Science Networks. And as part of, we're members of the Association of British Health Industry, there is an NHS interface there. The problem with working with the NHS is the fragmentation of primary care trusts. And it's a very challenging place to engage. So we're working with smaller, privately funded primary care clinics, and we've even set up our own community vehicle called Jamii Sasa, which is Swahili for community health, as you probably know. And that's chaired by Veronica Pickering, the Lord Lieutenant of Nottingham. Once we're ready to go to market, we really want to take this out to people and join it up with their telehealth provider, because this is the last leg of telemedicine. This gives you that virtual triage that enables everything else. Because up until now, you're relying on really good cameras and saying, well, you look a bit peaky, go in and see a doctor or do a postal test. Now, you've got a test that's going to take 30 to 60 seconds. Join up through an API to your online pharmacy or enable your telehealth provider to say, well, I've looked at your test and really we'd like to book you in for downstream appointments with consultants or secondary diagnostics. So I think it unclogs bottlenecks. And we want to work with as many people as possible. When you look at the UK, 7.5 million people are waiting on the NHS for their first diagnosis. That's 10% of the population, just under. Discuss that with the FDA, with the CDRH. They thought that in the US, that figure, that percentage, was several percent higher. And we're very proud to be part of the FDA's Home Health Hub initiative, because we want to get our device out to people in their homes, in their community centres, in their clinics, through their companion organisations, and connect people who just can't afford private health insurance to their providers in the area. Can you imagine that in an hour, face to face, you could probably see 3 or 4 clients, but with this, and with virtual care and with the speed of diagnosis, one healthcare professional could probably see 10 people. That could unclog the system.
Is it conceivable that, Medicare could distribute it or Medicaid?
It's designed for it. I met with a CMS. I think this would fit with Medicare's goals of value-based care for the future. It's designed for that. Very cost effective, very productive. It is part of the design, and we welcome that ongoing engagement with them.
Yeah, Paul, talk about the way you want to launch and the United States piece of what we were talking about before we came on record.
Well, the US is very important to TachMed. It's the way that healthcare is provided and funded, the increased role that a lot of the bigger organizations play in building health equity and value-based care really aligns with our strategy. So we already have a couple of our team based out of the East Coast. We have a very small office in Virginia, and we're looking to build out our main operations out of Arizona, but the US is a very big place. But we're working with several groups that have accelerators and such like to really try and user studies, use cases, and get some feedback as to how best for us to distribute this through the system on a B2B basis. So we really want to go through those providers and reimbursement companies that can help us reach their members.
So when do you anticipate potentially launching in the United States?
Summer next year.
Summer of next year. Okay.
And we would love to be part of an accelerator that we've applied for in May next year. But either way, a number of partnerships. We're talking to veteran associations and people like that. We would love to get those projects working spring, summer next year, and then to really go on from there. But we're committed to establishing more research and development, manufacturing, and distribution in the US from East Coast to West.
Do you want to talk about the funding piece since we are talking with LeagueMed?
I know, just coincidence having you guys here. So we've raised today through pre-seed and seed about $10 million. And we're now raising another $10–15 million to fund going to market and scaling. That's a Series A round. And we would love to hear from anybody that is aligned with our longer term goals. We love working with family offices. I was really interested in your comments about the mass affluent and such like, stepping into the gap left by venture capital, coming from hedge and private equity, alternative investment world. I can see how private equity has moved into a huge space and venture capital has stepped into where private equity used to be. Really, that ultra high net worth mass affluent space has a role to play in bringing new technology to market and facilitating that ramp into high growth and scaling. So, in the UK, we've used tax efficient schemes to bring that kind of funding in. We've been very fortunate to benefit from non-dilutive funding from AWS. So as a corporate strategic, they've stepped in where grant authorities would not normally step in with private companies like ours. So we haven't spun out of a university. So a lot of the typical Innovate UK and other grants weren't easily accessible. AWS has filled that gap for us and given us prime access to hard to access AI chipsets and Gen AI models and other resources like that. So private capital, very useful for us and will help get to a larger speed in the future.
Yeah, I mean, this is right in our wheelhouse in that diagnostics, AI, and health IT, these are all priorities for us. That and devices are where we want to play. I mean, we're not into biotech and pharma and, things that have the promise will only be realized on the other side, the far side of the horizon.
Well, we should talk.
Yeah, absolutely. And I would mention too that, well, the thesis that brought Paul and I together, which was to build this digital platform and speak to the mass affluent, broadly speaking, and the healthcare professional in particular. We do have some, you might say, institutional salespeople. That's kind of my background, to a certain extent, it's Paul's background, and other guys on the team where we can speak to family offices and we can solicit larger sums directly. For example, we have a good dialogue with family office Alex Gorski, who until 18 months ago was the chairman and CEO of J&J. So he and his son run their family enterprise and groups like that. So we're very engaged with institutional investors as well as, through this medium, the mass affluent.
We value that. Fundraising is hard, whatever you do. And I've done it through hedge and private equity. And when we launched our agricultural fund, I raised $540 million in January 2009. And I felt like a hero. I've raised $10 million over the last 6 years for this venture. And I can tell you that was an awful lot harder. You wear the scars on your back from going through that process.
Yeah.
But we're very much a mission-led business. We're persistent. We're going to get there. We have a really big vision. We see ourselves as the front end of this emerging new digital health ecosystem. And I've seen how difficult it is to generate sufficient digital health data to drive the products and services that so many other very ambitious and much, much larger organizations are trying to achieve. So I think the opportunity for any of your investors here is to own the front end and to use data to drive what everybody else is in a very exciting way talking about, but is unable to do because they don't have the data.
John,
Ron's familiar.
Yeah, it does. John, I give Paul Tilla the last few words, and why don't you let's flip this a little bit and talk about what LeagueMed needs or wants. So in terms of the type of people you want to come and visit LeagueMed.com, you want to share a little bit about that?
Yeah,
John?
you can take it, John.
Yeah.
Look, we're the predicate for success in our business is building a large community of members. Membership is free. There's lots of benefits attending it. We have a benefit program, discounts on travel and entertainment. We have continuing medical education. We like to think, institutionally credible and insightful content about the business of medicine, the innovation ecosystem, the utility of alternative investments. But that's all in the service of financing, innovations such as we've been speaking about, for much of the last hour. That's what it all points to. That's why we exist. That's what we're trying to achieve ultimately. And that's, quite frankly, how we build enterprise value here. So we're just starting to build that community. We have some institutional partners who are helping us do that. Paul's been very involved in this community for many, many years. I sort of came at this from asset management. And we too are still in our early stages. So we are fundraising to grow our business, but creating a community is the most important thing here, is to get people to visit our platform, join the platform, consume the content, and we hope in due course invest in projects like Paul is leading and others who are going to make a difference in how healthcare is, delivered to the people who need it.
Thank you so much. And I just want to say thank you to you. Thank you to our special guest, Paul Christie. Paul Chella of KeyArcs, thank you so much. Love working with you. And Dr. Angela, wonderful. I love what you're doing in Africa, and also wondering if that BioPanda piece might fit somehow with what you've developed already and where you're going with healthcare. I think resonates with what TachMed's all about. And so I can definitely see some collaboration. So thank you, everybody. Go visit TachMed.com.
Thank
Go
you.
visit LeagueMed.com. And
I'm on it already.
yeah, definitely. We thank everybody, and I really appreciate you joining us for this episode.
Take care.